Good afternoon. I will be speaking on the cardiopulmonary consequences of mitochondrial disease. Cardiac muscle has high aerobic metabolism demands, thus patients with mitochondrial disease are at high risk for cardiac complications. In one study of infants and children hospitalized with mitochondrial disease, those with existing cardiomyopathy was reported to have a higher mortality rate than those without cardiomyopathy. The two main types of cardiac complications in mitochondrial disease include 1. Cardiomyopathy, and 2. A heart conduction defect. Severe cardiac manifestations have also been observed, and this includes acute heart failure and a severe form of arrhythmia called ventricular tachyarrhythmia. Both of these can worsen acutely in a crisis. Sudden cardiac death related to atrioventricular block has also been observed. There are 3 types of cardiomyopathy seen in mitochondrial disease: dilated, where the cavity of the heart is enlarged and stretched; hypertrophic, where the muscle mass of the left ventricle is thicker than normal; and non-compaction, where the left ventricle contains trabeculations. 40% of all cases were reported to be hypertrophic cardiomyopathy in one particular paper. The symptoms can range from being asymptomatic to having lactic acidosis and exercise intolerance, and at the severe end to having devastating multisystem disease. It is important to note, though, that in general, in the majority of patients, it takes many years to develop cardiomyopathy. However, in some, cardiomyopathy may develop acutely in the context of metabolic stress associated with intercurrent illness. In general, though, cardiomyopathy occurs in the context of a person with existing neuromuscular weakness, so they're weak, and they may have existing liver and kidney problems. Although we do know that there are specific genetic etiologies where the prevalence of cardiomyopathy alone or just with myopathy is higher, and not necessarily in the context of multisystem disease. When we look at the muscle biopsies of heart muscle in those patients with mitochondrial cardiomyopathy, the structural differences are not too different from skeletal muscle. And so what you see here is the image on the left, stained pink, so with a standard H&E stain. The heart muscle fibers are hypertrophic, so they're larger than normal, and vacuolar, so they're more circular. A better look at the abnormalities of the mitochondria in the heart muscle, though, is by electron microscopy. So the top image here, the black and white image, shows normal electron microscopy images of mitochondria, where you can see the trabeculations of the mitochondria are nice and linear and well organized, compared to the more disorganized appearance of the mitochondria crista down below in the image in the bottom, where the mitochondria are larger, they're concentric, and they're circular. And this was obtained from a patient with mitochondrial cardiomyopathy. Now moving on to arrhythmias, we do know that specific syndromes carry a higher risk for this. Essentially all patients carry a high risk for arrhythmias. It can happen in any patient, but we do know that specific syndromes carry much higher risk because it's been well described. If you go into the literature and look up Kearns-Sayre syndrome and heart block, there's an abundance of case reports of patients being reported with either early identification, late identification, or unfortunately succumbing to the atrioventricular block. So patients with Kearns-Sayre syndrome are predisposed to AV block. This can present as syncope, where they would faint, and Adams-Stokes syndrome, or sudden death. In these patients, in general, the retinopathy and the ophthalmoplegia, so the cardinal features of Kearns-Sayre syndrome, would be pre-existing before the heart block develops. This is in most cases, but we don't want to be caught by surprise. So when a patient's been diagnosed as Kearns-Sayre syndrome, it is important to establish cardiology care from the very beginning and to ensure that patients are seen every 1 to 2 years, depending on any abnormalities found, or in those with existing arrhythmias every 6 months. A pacemaker needs to be placed at the first sign of a heart block. Why? because the progression from first degree to second degree to third degree heart block can be rapid. There's also reports of other mitochondrial DNA syndromes such as MRF, where it's been reported the higher risk of sudden death related to arrhythmias. So the take-home message is to always have these patients undergo close monitoring. Even if it was normal each year, it needs to be consistently assessed every 1 to 2 years. To review some clinical cases, a patient with Leigh syndrome presented with acute development of left ventricular hypertrophy after exposure to anesthesia. Fortunately, this was transient and resolved over a few months, but this is a good example of acute cardiomyopathy developing in response to exposure. In the second case, a lady aged 42 with a history of short stature, hearing loss, ptosis, meaning droopy eyelids, ophthalmoplegia, ataxia, dysarthria dysphagia, retinitis pigmentosa, heart block, pacemaker in place, and dementia, all consistent with Kearns-Sayre syndrome, developed weight loss for which a G-tube was placed. Unfortunately, at the age of 47, she was found at home and succumbed to what was concluded to be pacemaker failure, meaning she succumbed to the atrioventricular block. Moving on to the pulmonology complications of mitochondrial disease. So, in mitochondrial disease, there is no direct association with primary lung pathology, such as asthma or pulmonary fibrosis or hypertension. The specific concern with the lungs or breathing in mitochondrial disease is weakness of the main muscles that expand the lungs with each breath, that being the diaphragm, and also the intercostal muscles. So when these muscles are weak and or fatigued, this leads to hypoventilation. So with repetitive movement and contraction of the muscles, which fatigue over time, you get increasingly inefficient breathing. And the symptom of this is dyspnea. So dyspnea is a symptom of being out of breath. We closely collaborate with Dr. Jason Fritz, an adult pulmonologist at Penn, who sees all of our mitochondrial disease adult patients. He conducts a clinical evaluation where he closely thinks about the likelihood of lung pathology and excludes it, but also works closely with the cardiologist to exclude any primary cardiology pathology. So these are his examples of symptoms from either primary lung pathology or primary heart pathology, dyspnea being top of the list. So you can see where a person who presents with dyspnea needs to undergo a very thorough evaluation to ensure that it's not originating from either the heart or the lung, or in fact a combination of the heart, lung, and mitochondrial disease. So it's a very, very important evaluation. As mentioned in my earlier talk today, exercise intolerance is among the top 5 symptoms in mitochondrial disease. What is exercise intolerance? It's the inability to complete intended activity. As described by our patients, they are restricted by tiredness, feeling winded on trying to do activities. They may develop muscle cramps or feeling out of breath or dyspneic. A typical statement is, I need to stop halfway going up the stairs. Or exercise intolerance affects walking in school and going to school events and going for simple walks around the neighborhood. So the regular activities of daily life that occur in the general population are extremely effortful in mitochondrial disease. What is the underlying basis of exercise intolerance in mitochondrial disease? Tanya Taivasalo and Ron Heller studied a group of patients with confirmed mitochondrial respiratory chain deficiency, where the conclusion was that the exercise intolerance is because of the impaired skeletal muscle oxidative phosphorylation, or OXPHOS. What was proposed was that the blunted capacity of the muscle to increase oxygen utilization or consumption in relation to increased circulatory and ventilatory responses that normally occur following exercise was not as effective as would be the case in a person without mitochondrial disease. So this is a demand and supply issue. What would happen under normal physiologic circumstances is that contracting muscle increases the demand for substrate, meaning oxygen. The body compensates by increasing the heart rate because the heart needs to pump more blood flow to the contracting muscle to provide oxygen. At the same time, the body increases the respiratory rate because increased oxygen intake needs to be inhaled in order to provide the oxygen supply downstream to the skeletal muscle. So the problem in mitochondrial disease is that despite the increasing demand and despite the increased circulatory and ventilatory responses, which are physiologic, in a mitochondrial disease patient, the supply is not met, however, because the respiratory chain defect reduces the amount of oxygen that is consumed in the contracting muscle. What you get then, therefore, is the phenomenon of exercise intolerance. This shows the results of the study by Tanya Taibasalo, where they took 40 adults with mitochondrial myopathy, or MM, and compared to healthy sedentary controls. In the figures, you will see in figure A, there was a significant reduction in the measured peak work in the patients with mitochondrial myopathy compared to controls. Similarly, there was a significant reduction in the peak or maximal oxygen uptake. This is the oxygen utilization in mitochondrial myopathy compared to controls. This is measured by way of cyclo-ergometry or exercise testing, or cardiopulmonary exercise testing, which I'll refer to as CPET further in this talk. Also, they measured the arterial venous oxygen difference. This is the amount of oxygen that was extracted in the blood of patients with mitochondrial myopathy, and this was significantly reduced too compared to controls following exercise. So all of these results basically confirm the conclusion that I explained earlier, which is that the muscle oxygen utilization in patients with mitochondrial myopathy is defective when the OXPHOS activity is decreased as a result of the respiratory chain genetic defect. They did point out, however, that other diseases or disorders such as cardiomyopathy from non-mitochondrial genetic causes may also lead to similar results as shown in this figure. Also, patients who are physically deconditioned from other factors may also lead to results that are similar in this figure, meaning the exercise testing might be a false positive in patients with cardiomyopathy from other causes or with physical deconditioning, highlighting the possibility that exercise testing may not be specific to mitochondrial myopathy. In the same study, the measured heart rate, cardiac output, and respiratory rate, meaning the circulatory and ventilatory responses in those with mitochondrial myopathy, were exaggerated compared to the control individuals, which is consistent with the OXPHOS defect. And they found that there was a direct correlation with the severity of the OXPHOS defect and these exaggerated responses. Now, if you look at it from the other angle, instead of evaluating mitochondrial oxygen utilization, Britton Chance looked at oxygen levels in muscle tissue, so in contracting muscle tissue following exercise. He did this using near-infrared light, where they measured the level of oxygenated hemoglobin in muscle. And here, what was shown was, as you can see in this graph, normal individuals would drop their muscle oxygen levels with exercise, but in B, which is a patient with what was called mitochondrial myopathy back then, because they weren't genetically confirmed but had respiratory chain defect, the muscle oxygen level was higher than the baseline level, meaning the muscle tissue oxygen level increase with exercise instead of decrease following exercise because of the deficient oxygen utilization in the muscle tissue. Exertional dyspnea. This is similar to exercise intolerance, but presents instead with the perceived feeling of being out of breath following minimal or moderate exertion, where you wouldn't really expect it. We have to remember that exertional dyspnea is indeed a common presentation of heart failure or asthma or other lung pathologies, hence the importance of excluding those two big categories of disorders that may give rise to this particular symptom. Once those other disorders, meaning the cardiac and lung pathology, have been excluded, the mitochondrial disease is a very under-recognized cause of unexplained exertional dyspnea. This exaggerated ventilatory response is not well understood and presumed to be due to deficient oxphos, where patients have presented with this acutely. When the pulse ox is measured, the saturation recorded in general is normal. So there is no hypoxia being measured that accompanies the symptom of exertional dyspnea. So it's a very poorly understood symptom, but yet very common and very important, and further work needs to go into understanding and clarifying the basis of this particular symptom that is quite common in mitochondrial disease. What needs to happen is patients with exertional dyspnea need to be evaluated by a pulmonologist and a cardiologist. In terms of pulmonology evaluations, lung function testing is always performed, or spirometry, which is indicated by this figure below, where somebody needs to blow into a tube. I will say that mitochondrial disease patients generally demonstrate normal spirometry, or they may demonstrate restrictive lung disease, which is due to the respiratory muscle weakness. Following spirometry, further test evaluations would include imaging by way of a chest X-ray or a CT scan in order to evaluate for primary lung pathology. This slide was provided courtesy of Dr. Fritz, who is co-director of the Dyspnea program. What Dr. Fritz is showing here is the utility of cardiopulmonary exercise test, or CPET, which is exactly the same as cyclo-ergometry, as shown on the slide earlier. So patients undergo cardiopulmonary exercise testing in order to help exclude either lung pathology, heart pathology, and mitochondrial disease. This is the recumbent bike that is used to conduct CPET, and you'll see in the image on the right, not only are you sitting on the bike, but a mask is applied to your face because the exhaled carbon dioxide and inhaled oxygen needs to be collected and measured. Also, you'll have EKG leads, a pulse ox placed during the entire assessment. This is what is involved during CPET testing. You're instructed to wear comfortable clothes and eat your breakfast as usual on the day of testing. When you arrive, they'll perform lung function testing or spirometry, and then you'll be asked to sit on the bike. The mask will be placed, and you will acclimatize to the leads and the contraptions for a few minutes until you're comfortable and not anxious before the measurements start. When the test begins, you're asked to pedal the bike without resistance for a few minutes, and then they follow a standard incremental protocol where more and more resistance is added depending on time. You'll be asked to keep exercising until you absolutely cannot go any further. So what is measured during this assessment? Everything. So the heart rate in EKG, the amount of work performed in watts. This provides the results for the parameter shown earlier called peak work. The minute ventilation, which is the volume of air shifted in your lungs. The oxygen and carbon dioxide levels, your blood pressure, and a particular important parameter is the amount of oxygen your body takes up from the air called VO2, and the amount of carbon dioxide expelled from the lungs per minute. At CHOP, we routinely recommend CPET to all of our patients, both adult and child. The child patients have CPET performed here at CHOP, and the adult patients are evaluated by Dr. Fritz. What you'll see here is a summary of our results presented in 3 graphs based on the 3 parameters. So On the left is maximal oxygen consumption, or VO2. This is the measurement for aerobic capacity. In the middle is the peak work measured, so this is the physical capacity. And then on the far right is the anaerobic threshold. This is the point at which your plasma lactate begins to rise during exercise. So what we did is we compared a cohort of individuals with mitochondrial myopathy compared to historic controls or normal controls that have been seen in the cardiology lab here at CHOP, as well as those with treated cardiomyopathy, meaning patients with cardiomyopathy from other genetic causes which are non-mitochondrial disease, and they're being managed. So what we did was define the likelihood of a subject having mitochondrial myopathy. So they were definite if they had a genetic etiology, or probable if the chances were very high that a genetic etiology would be identified, compared to possible and unlikely. So the first thing to say here, if you look at the graph on the left, is the VO2 max, which is the aerobic capacity of those individuals with definite or probable mitochondrial myopathy, was significantly decreased compared to normal healthy controls and cardiomyopathy, but also in comparison to those with possible or unlikely mitochondrial myopathy. There was a similar decrease in the physical capacity of those with definite myopathy compared to controls, as well as the anaerobic threshold, but they were not significantly different when compared within the mitochondrial myopathy groups, probably related to the relatively low numbers of patients. So what was found was that the VO2 max, peak work, and anaerobic threshold had ability to define patients with definite and probable myopathy as compared to normal controls. Also, the VO2 max was significantly lower and able to discriminate, therefore, those with definite and probable myopathy as compared to the possible and unlikely group. This is a very key point because those with possible or unlikely myopathy had a high chance of being physically deconditioned. And what was stated or proposed in the literature was that CPET was less specific for identifying myopathy because of the possibility of deconditioned people having false positive results. However, in the cohort presented here, those with physical deconditioning or less likely to have myopathy had in fact significantly higher VO2 levels compared to those with definite and probable, meaning their peripheral oxygen utilization defect was not as low as those with definite and probable myopathy. So this is a very important point because, in fact, here at CHOP we utilized CPET as a diagnostic test. So the assessment provides us with insight into the aerobic capacity of muscle without performing a muscle biopsy. It's another piece of the pie in terms of providing a different measurement in the interpretation of the results as a whole towards making a diagnosis of mitochondrial myopathy. However, there are limitations to the application of CPET in mitochondrial disease broadly. The first is the height and age restriction. Patients need to be at least 135 centimeters and of a certain chronological age to be able to understand and follow the commands during the assessment. Also, it can be very technically challenging for patients with imbalance or spasticity or dystonia, or those with cognitive deficit. So this essentially means that the application of CPET in mitochondrial disease is restricted to perhaps about 30% of our clinic patients. The other caveat is that the results of somebody with mitochondrial disease and cardiac disease can look nearly identical on CPET, which is something that Dr. Fritz has observed in all of our assessments. This is because those with cardiac disease too have decreased VO2, but this is from a different problem here. Their heart is not able to pump effectively more blood flow to the contracting muscles. So there is more of a supply issue from the point of the view of blood flow, whereas in mitochondrial disease it's a supply issue because of the impaired oxygen extraction in muscle tissue. So The other problem that has been observed is that those with primary mitochondrial disease may produce similar results to those with secondary mitochondrial dysfunction, because in both cases, where one is genetic and one is not, the impaired oxygen utilization is present, and therefore the ability to discriminate between someone with a genetic defect versus someone who doesn't have a genetic defect for mitochondrial disease but might be from another disorder or perhaps exposure to certain medications that were mitochondrial toxic may produce fairly similarly low VO2 levels on exercise testing. So this highlights the importance of integrating the results of CPET with all other aspects of the clinical diagnostic testing. But given that the utility of CPET in mitochondrial disease is restricted to not all patients, particularly those who are non-ambulant, more work needs to be done to establish another clinical quantitative measure of exercise intolerance or exertional dyspnea, mitochondrial disease. This is now on a research basis. We're looking into the utility of quantitative dynamic MRI in order to quantify diaphragmatic muscle contraction and lung volume. So more to come in this space. Now in the last few slides, I'd just like to introduce what Jean Flickinger, our mitophysical therapist, does in our clinic at CHOP. Patients are seen where different domains are measured, which are very much integral to the muscle impaired oxidative phosphorylation. So strength is measured, the functional ability of the patient is measured, balance and coordination, and muscle fatigue is measured. Jean's clinical assessments provide quantitative values that enable us to follow patients over time and now track their exercise intolerance and physical muscle fatigue, which has never been done before. In addition, we're looking into the possibility of establishing effective and safe exercise programs. This is a further area that needs to be studied, but we're looking at endurance-based and strength-based exercise, the use of orthotics, the use of equipment that would enable a person with muscle weakness to participate in exercise. We utilize cardiac rehabilitation programs, and we utilize balance rehabilitation programs. We know from the literature that exercise is beneficial in mitochondrial disease. This has been shown in animal studies and human studies. There's evidence to show that exercise training can improve the tolerance, your exercise intolerance, your peak capacity for work, even the oxygen utilization, and improve quality of life. So there's a lot of literature, particularly from Mark Tarnopolsky, on the studies in animal models of mitochondrial disease and in humans. However, it needs to be pointed out that if the exercise is stopped, the benefits merely are replaced by the baseline performance of the individual before the exercise program was started. The studies currently that are there are limited, and that further research needs to be done in this arena, but it's a very important area of study. We're also looking at strengthening our resistance exercise in terms of increasing one's endurance and fatigue. So this is a slide from Jean. She's very proactive in evaluating existing equipment and contraptions out there that might enable or provide added support to our individuals, particularly those who have significant muscle weakness or are non-ambulatory, to encourage the possibility of participating in active exercise. At the same time, we're also looking into studying the application of passive exercise in our patients. In conclusion, all mitochondrial disease patients should complete repeated clinical evaluations with a cardiologist, and if muscle weakness or fatigue is present, with a pulmonologist. All mito disease patients are at risk of cardiac morbidity, particularly certain genetic syndromes such as Cairns-Sayre syndrome. Mitochondrial disease should be considered in the differential diagnosis of unexplained exertional intolerance or dyspnea. CPET testing can be useful in the diagnostic evaluation of these patients, and further study is needed to establish personalized exercise programs that are safe and effective, and the utility of passive exercise in patients with mitochondrial disease. Thank you very much.